This is our second annual Arizona AIM Collaborative Conference, which is hosted by the Arizona Hospital and Healthcare Association, the Arizona Department of Health Services, and ACOG's Alliance for the Innovation on Maternal Health, which of course is AIM, which is what you all are familiar with and why you're here today. We are absolutely thrilled to see so many dedicated healthcare professionals, leaders, and advocates here today, all united by a common goal, and that is to improve maternal health and promote health equity in our great state of Arizona. Talking a little bit about the work that we've been doing over the past a little over 2 years. Just about April of 2021, in April of 2021 is when we did our kickoff for the hypertension work. Many of you were with us when we held that kickoff remotely because we were in the middle of COVID, and we had Dr. Ann Borders join us. We had a wonderful, wonderful event, and you all went to work and started collecting data, submitting those data, and now through the course of time up until now, really working on all those quality improvement projects to improve the outcomes for our birthing for our people in the state of Arizona. So with that, I'd like to just run through some of the outcomes that we have to date. We're really excited to share these data with you. And I want to remind you that as a steering committee, we made a decision that we were going to focus on two main drivers for maternal morbidity and mortality. And those are time to treatment and then debriefing. So time to treatment has to do with making sure that we're treating those individuals who are experiencing blood pressure over 160 systolic or 110 diastolic. If they have a second episode within 15 minutes, that they are treated within 1 hour. So that's the first metric. And then the second one is if we didn't treat within 1 hour, try to figure out why not and make plans for the future. So that is oftentimes accomplished through debriefs, which are generally done that day, and not required, but generally are done that day so that opportunities for improvement can be identified. And you can see from the data there that in our baseline, we were at 55% of people treated within 1 hour, and we have actually increased in our last quarter to 72%. We're not quite at our goal of 80%, but we're up to 72%. And for debriefs, you can see that we were at 11%. That was a heavy lift to implement all those debriefs, and we've gotten up to 41%. So our hats off to you. You've done a really good job with improving those outcomes. So this puts it all together in one place. You can see here that our patients treated within 60 minutes have gone up. We're almost at that 80% mark. Those that were not treated but were debriefed have also gone up. And the ones that were not treated and not debriefed have gone down. So everything's going in the right direction. In terms of provider education, we wanted to know, and AIM is asking us to report, the number of providers who have reported, or the number of hospitals that have reported that 80 to 100% of their providers have completed education within the last 2 years. And you can see here that increase from 2021 to 2023. And in the next slide, you'll see nursing education, also up from 2021 to 2023, all the way up to 94%. Great job. And then in the next slide, in this slide, you'll see we've added another component. So when we first started out, we were very much focused on labor and delivery. And in 2022, AIM redid the bundle and added some metrics for the emergency department. This is one of them, and that has to do with, I'm jumping ahead. So this is provider education for respectful and equitable care. And you can see this is new for 2023 with the revision of that bundle. And we are starting out at about 37% of providers having completed that. And then for nursing education, we're at about 53% of nurses having completed that education. And then for ED education, which is what I started to talk about, we're looking at education of ED providers and nurses. And you can see that we have a baseline of 36%, so some room for improvement there. And in our next slide, you can see that we've also added screening in the emergency department. It's very important to know when people present whether or not they are postpartum. And so there are some algorithms that can be put into place and protocols that are started if someone presents, especially with hypertension, in that very critical period after giving birth. So we started looking at how many hospitals in their ED have a standardized verbal screening for current and recent pregnancy in place. And we are at 48% of hospitals reporting that they do. And hospitals, many of them are going back as far as 1 year. So they're asking, in the last year, have you been pregnant or given birth? And so that is really great. That really is the gold standard. So great job for those of you who are doing that. And then another new standard that was added is making sure that we have follow-up visits scheduled for people who have experienced severe hypertension during that birthing admission. And you can see there that we have a little ways to go. There are a few hospitals who are completely green, meaning that they are 100% implemented, and there are some that have not started this yet. This is really a tough one. We know this is a hard one to implement in workflow. And then in the next slide, these are visits that are scheduled for people who have experienced other hypertensive disorders. So we're doing better there. Green is good. You see a lot of green on that slide. So great job, everybody, for getting that work done. So again, want to remind you that one of our main goals is that time to treatment. We are doing well with our improvement, but we don't want to take our eye off the ball, and we are going to continue to work for that 80% and even keep going from there. And then also for those debriefs. So we've made steady increases, but we really want to make sure that debriefs are part of the culture and are completely incorporated in that. So good job, and we will continue to still collect and report on the hypertension metrics because we don't want to take our eye off of this. Although we are here today focused on kicking off the hemorrhage bundle. But we did definitely want to let you know how you're doing and celebrate with you today how the incredible improvements that you've made over time. So with that, I'd like to introduce our colleagues from the Arizona Department of Health. They are our first speakers. Heidi Christensen is a program manager with the Department of Health and is our AIM State Lead Coordinator for Arizona. And joining her is our two maternal and child health epidemiologists, Glenda Ramirez and Samantha Davidson. Together, they're going to present the Arizona State hemorrhage data. Everything we do in quality is based on data, right? We always want to make sure that we are paying attention to that. So their presentation will promise to provide valuable insights into the data that informs our efforts to reduce maternal mortality and morbidity in Arizona and help you understand why we chose the hemorrhage as our second bundle. So without further ado, let's warmly welcome Heidi, Glenda, and Samantha to the stage. Thank you.
I want to welcome you all here today, and like Vicki said, I'm really grateful to all of the work that you guys are doing in the hospitals, making sure that our birthing individuals and their families and their infants are healthy and surviving the birthing process. I wanted to start off my piece with a land acknowledgement because we are on tribal lands. So every community owes its existence and vitality to generations from around the world who contributed to the hopes, dreams, and energy to making history that led to this moment. Let's all take a moment to acknowledge the ancestral homelands of the tribes in Arizona and acknowledge that the lands within and surrounding present-day Phoenix, the Phoenix Valley, are traditional homelands and gathering places of indigenous peoples. And I'd like to specifically recognize the O'odham and Pipash peoples who have stewarded this land since time immemorial. We pay respect to their elders, past and present. We're grateful and appreciative to those whose territory we reside and work on today. And just as part of that, I want to highlight we've got all of the tribal communities that are in Arizona, all 22 federally recognized tribes, are participating in maternal health work, including the AIM work that we're doing, and we want to welcome them to this space too. And I'd like to just highlight a few things. So our AIM work is really positive, and we get wonderful feedback from National AIM about the engagement that we have here in the state. And we started during the pandemic here. Some states started before and had a better established program, and I just think it's amazing and really shows the dedication that you all have to what you do, that during the middle of a pandemic and things being very stressful. And I know that there's work shortages, and you guys have stepped up and really been the ones to move this work forward. As a state, we're working on maternal health initiatives in many other areas. I'm just going to highlight a couple. One of the areas is our perinatal mental health. And there's a perinatal mental health access line called APAL. I don't know if you've heard of it, but if you haven't, please reach out. I think there's some information at one of the tables too. And APAL is a perinatal psychiatric access line. It is specifically for prescribers. It's there to support those who are providing services to pregnant and postpartum women that may need medication for their mental health conditions, and but don't have access to somebody with that training. So their physicians would be able to get that support to be able to give those services to them. We're also doing a lot of training around perinatal mental health and getting individuals certified. And because our goal is to have at least, we want more than this, but at least one provider that's certified in every county in our state. We're not quite there, we're getting closer. There's 3 tracks for the certification. One is for mental health providers, which is a heavy focus that we're going towards, prescribers, and then also the affiliated professionals. So anyone working with the perinatal population, so nurses, doulas, case managers. There is another certification track that you could be eligible for. We do have scholarships that are available to get that certification, and a lot of information and support around that. We just want everyone to have a better foundation of what to look for and how to help and address those concerns. So, and we also know there is an AIM bundle that is focused on perinatal mental health, and in Arizona, perinatal mental health conditions are one of the leading causes of maternal mortality and severe morbidity. So we do want to continue to work on that, and we want to make sure the infrastructure is established in the state before we take on that bundle, because we know you all see families for just a very short time during the birth process, and but we want to give you the resources you need to be able to refer them once they're out of your care. I'm going to move on to my colleagues, Glenda Ramirez and Samantha Davidson, and they're going to talk about the hemorrhage data piece. And clicking from here. All right, I'll hand it over to them. Thank you so much.
Well, good morning. Again, thank you so much for being here with us today. As Heidi mentioned, I'm Glenda Ramirez. I'm one of the maternal health epidemiologists working with the Arizona Department of Health Services. And I'll go over a little bit of maternal health outcomes data with you all, but then I'll go ahead and pass it over to my colleague who recently joined our team. We're very excited to have her. She's another maternal health epidemiologist working with the state. So to start off with, we do not have any conflicts of interest to disclose. However, we do ask that the distribution and sharing of the slides be limited to meeting attendees, particularly for those slides, especially where the data is still indicated as preliminary. So we'll start by noting that the goals are that by the end of this presentation, audience members will generally understand obstetric hemorrhage trends and its overall impact on maternal health outcomes. That audience members will understand the surveillance methods that we implement for obstetric hemorrhage for pregnant individuals in Arizona. That attendees will have obtained information on severe maternal morbidity data trends in Arizona, and that by the end of our presentation, attendees will be able to identify areas of opportunity to prevent future obstetric hemorrhaging through some of the interventions commencing or that are currently underway. So many of you may be familiar with this pyramid, but generally speaking, it is often a good place to start when considering maternal mortality and morbidity. We often refer to this visual because it clearly demonstrates the spectrum of potential maternal health outcomes during pregnancy and soon after pregnancy. The base of the pyramid represents the most common scenario of uncomplicated pregnancies, but then as we go up the pyramid, we see the less common but more severe cases of maternal morbidity, severe maternal morbidity, maternal near miss, and then maternal mortality. Both public health professionals within both the Bureau of Assessment and Evaluation and in the Bureau of Women and Children's Health at ADHS, we pay special attention to the top 3 scenarios on the pyramid in order to better understand and improve maternal health outcomes here in Arizona. Cases of maternal mortality receive individual level case reviews, while cases of severe maternal morbidity and maternal near miss receive more of a high level epidemiologic analysis. We'll discuss maternal deaths a little bit today, but we'll mainly be focusing on severe maternal morbidity, which we often refer to as SMM. And these are unexpected outcomes of labor and delivery that lead to significant short or long-term consequences to a woman's health and well-being. So here in Arizona, we identify maternal deaths through the Maternal Mortality Review Program. And generally speaking, we identify cases through our Arizona Vital Records system. Once cases have been identified and once the MMRP abstraction team has requested, reviewed, and summarized individual case records, the Maternal Mortality Review Committee categorizes each maternal death case according to its relation to the pregnancy. This means that we gain an understanding of which cases are pregnancy associated and which cases are specifically pregnancy related. When we say pregnancy associated cases, these include deaths of women while pregnant or up to 1 year after the end of pregnancy, irrespective of the cause of death. A subset of those cases are considered pregnancy-related, and these are deaths of women during pregnancy or up to 1 year after the end of pregnancy that stemmed from a complication, a chain of events initiated by the pregnancy, or an unrelated condition that was aggravated by the physiologic effects of pregnancy. So looking really quickly at this graph, we see 2-year mortality ratio trends that include 2016 and 2017, and then 2018 and 2019. In the red, you see the overarching pregnancy-associated mortality trends, and just below it, in the orange, you see the pregnancy-related mortality trends. Both groupings do show an increase in these ratios. The 2018 and 2019 data show that for every 100,000 live births in Arizona, there were about 91 pregnancy-associated deaths. And then in the orange, the bottom line, for every 100,000 live births in Arizona, there were about 26 pregnancy-related deaths in Arizona among birthing people ages 15 to 49. And then looking at severe maternal morbidity, we looked at Arizona statewide annual trends from 2018 to 2022. SMM events are identified through the Arizona Hospital Discharge Database, or something that we call HDD, which consists of administrative health records submitted by hospitals throughout Arizona. Using the HDD, we identify SMM events through the ICD-10 diagnosis codes based on AIM inclusion criteria and guidelines for identifying these events. So at a quick glance here, you can see that there have been some slight variations throughout the years, but generally there has been an uptick in SMM events. In 2018, we found that for every 10,000 birthing admissions in Arizona, there were 67 SMM events found. And then in 2022, we saw that for every 10,000 birthing admissions in Arizona, there were nearly 84 SMM events included. And so now we'll slightly shift gears now, and we'll touch on obstetric hemorrhaging, which is the focus, again, of today's meeting. And I'm going to go ahead and hand it over to my colleague, Samantha Davidson, to go over that with you.
Okay, so generally speaking, maternal hemorrhage is defined as the cumulative loss of 1,000 milliliters or more of blood that is accompanied by signs or symptoms of hypovolemia within 24 hours after the birthing process. So why should we implement the hemorrhage patient safety bundle here in Arizona? There are several reasons for moving forward with this bundle that we'll touch on today. Starting at the very macro level, obstetric hemorrhage is an international concern. As previously mentioned, postpartum hemorrhage, or severe bleeding after birth, is the leading cause of maternal deaths worldwide, resulting in about 14 million women experiencing hemorrhaging each year and approximately 70,000 maternal deaths. Even when a birthing person survives, surgical intervention may be needed to control the bleeding, leading to potential lifelong reproductive disability. Just this year, the World Health Organization held an international summit to highlight the concern for worldwide maternal hemorrhage and to develop innovative ways to reduce these adverse outcomes. More specifically, hemorrhage is a concern in the United States. A 2019 report by the CDC demonstrated that hemorrhage was the second leading underlying cause of pregnancy-related deaths. And again, by pregnancy-related, we mean maternal deaths either during pregnancy or a year after pregnancy that were directly due to the pregnancy itself. And on the right-hand side of the slide, we see a table taken from the CDC report I'm referring to, where it shows hemorrhage accounting for about 14% of deaths. Apart from the mentioned CDC study, other research papers have shown consistent results and even rising trends of maternal hemorrhage in recent years. It's a bit hard to see, but on the right-hand side, we see a study that looked at different types of postpartum hemorrhage. And the key takeaway here is that the top blue line shows all postpartum hemorrhage, and there we see an increase in these rates from 1994 to 2006. And similarly, obstetric hemorrhage is a concern here in Arizona. When implementing the obstetric hemorrhage patient safety bundle, National AIM looks at two different SMM outcome measures within this bundle. The first outcome measure you see here is what was previously shown, which is SMM events per birthing admission, resulting in nearly 84 SMM events for every 10,000 birthing admissions in 2022. The second measure of interest is when we start looking at trends according to obstetric hemorrhage events. Again, we do this by monitoring events through the hospital discharge database by the ICD-10 codes you see listed here. I won't go through those. They're quite lengthy. These are definitely too small to read through, but this is what we as epidemiologists use to track hemorrhage events in Arizona. It includes a total of 118 ICD-10 codes that are categorized into the four groups you see listed: postpartum hemorrhage, previa, abruption, and antepartum hemorrhage. So going back to the slide I just shared, we see the amount of SMM among all birthing admissions in Arizona in the bottom orange line. What you see in the red line above is the SMM events for every 10,000 obstetric hemorrhage events. When we look at the rate with a focus on hemorrhage events, we see that for every 10,000 obstetric hemorrhage events, there are about 550 SMM events. Although there has been a slight decrease from 2018 to 2022, overall, the rates are much higher among hemorrhage events when compared to general births. And then looking at maternal mortality here in Arizona from 2018 to 2019, we have similar findings to that seen in the CDC report that I mentioned earlier, where hemorrhage is the second most common underlying cause of death among pregnancy-related deaths here in Arizona. So that was a very quick glance at plenty of data that we hope conveys the importance of addressing hemorrhage here in Arizona. Moving past the data, we want to finish by stating that, as we mentioned, hemorrhage is a leading cause of maternal deaths, both here in Arizona and worldwide. But even when birthing people survive, obstetric hemorrhaging can lead to many adverse outcomes, like some of the ones you see listed here. It can lead to shock, severe changes in heart rate or blood pressure, anxiety, depression, and lifelong reproductive disability, just to name a few. And these numbers all represent the countless lives that we serve daily and their children, family, and loved ones. So these slides will be made available along with the references used for the presentation, and we're happy to take any questions for either myself, Glenda, or Heidi. Thank you.
I don't know that I need that, but okay. I wanted to know, I was kind of shocked by the mental health being the first cause of death. Is that in correlation with addiction and dependency?
I would have to pull back up that paper, but I can assure you in the references that we listed in the presentation, we have a link to that paper. Glenda, do you know off the top of your head about that one?
I can answer that a little bit further. Okay. Sam's totally right. We do suggest that you take a look at some of the references here, but that is something that has been a concern statewide, nationally, especially when we look at the links between it's not necessarily 100% of the time that we need to consider mental health with substance use disorder, but there is this steady increase in both, or mutually exclusive, like separately, mental health, anxiety, depression, several other trauma that has inflicted some of those concerns, but then also substance use disorder and the increasing use of just several different substances, thinking of the opioid epidemic and the rise in fentanyl lately, but there's several different substances that have been correlated with those mental health outcomes, and that's something that we'll very likely be elaborating on in our maternal mortality report, where you go into underlying causes of death, and that'll be explained a little bit further specifically here, but there is that strong correlation there.
Do you think there's enough of a correlation that at some point it's going to become its own box of, I can't use words this morning. Thank you. Its own bundle.
So I probably am not the best person to talk specifically about the bundles, but like Heidi did mention, there is a bundle that focuses on mental health, and that is something I think that was considered at some point to implement a mental health bundle. I can't remember exactly its correlation with the substance use disorders or substance use, but there has been consideration for that. I will say, and Heidi, please, wherever you are, correct me or anyone, but there are several mental health initiatives and programs and services that are currently being offered in our state to be able to work on those concerns. And that was actually one of the reasons why hemorrhaging was selected. The steering committee for our state put a lot of thought into which of the bundles to consider, and that was a strong consideration for that one, but just being other services that are available in the state right now compared to hemorrhaging, that was one of the decisions that was made. The mental health bundle information is available online, so that could be something that people refer to more individually or at a systems level, but that was something that was potential. Yeah.
Thank you.
Yeah.
Good morning, and thank you for your presentation. Under one of the slides, you excluded CVA and aneurysm. Where are those included?
That is a great question. I will say that's actually based on standards set by CDC. They purposely wanted to exclude those two groupings. So anytime you look at any CDC report or any maternal mortality review program data, it tends to exclude that. And we can get back to you on specifically what group that's in, but we will also be including those details in our specific statewide report, but that is based on like CDC standards.
I appreciate that. Thank you. Just with the concern for severe hypertension and our treatment within that bundle, it just seems odd that when we're looking at maternal mortality, that is excluded. So I understand CDC says do this. Feels like maybe we should look at that as well, just so we understand what those numbers look like.
Yeah, absolutely. And I will say that it's not necessarily that it's excluded from the data. It's just excluded in the category that it falls under. So what that probably means is for those cases, they fall under a different category that CDC determined that doesn't have such high rates or proportions within our state. So it's not necessarily, I should have clarified, it's not that it's excluded from the data altogether, it's just the category that it falls on, which is one of the lower tier in that proportion.
The age range 15 to 49 is quite broad. Have you looked at the data in smaller groupings of age ranges, and what have you found?
Yeah, that's a great point. Thank you for that. So that actually used to be the standard that was requested by a lot of different agencies, especially CDC. It actually was recently changed to broader. So now it's actually ages 10 to 60. But we do look at outcomes as, right. But we do look at data stratified in different age groups because you're right. I mean, just like with a lot of these, we do see different trends, different associations based on different groupings. And so we do definitely want to look at data for different groupings, whether it's 5-year intervals, 10-year intervals. We will say just briefly, and again, we'll refer to our reports and the ones that are to come, but usually the trend for both maternal mortality and morbidity, it tends to be highest in the outlying groups. So primarily in the older age groups, and then also somewhat the younger. But yes, it tends to be in the outlier groups that is higher, yeah. And it actually, I think, from what I remember seeing, it was above 40, above 45 is usually when you do start seeing the change in the curve where it goes higher in that age range. So, right. And there are few cases in that 60 range, yeah.
All right.
Thank you, everyone.